So I'll pick up our discussion here, and I need to add one other thing. So in class yesterday, I introduced the intercostals. External intercostals, fibers run in the direction of your fingers when your hands are in your pockets. Internal intercostals, fibers run in the direction of your fingers if you put your hands in your armpits. They're at 90 degrees, so even just remember one of them. Hands in pockets, and then the opposite. I should add the innermost. Where are they? Oh, I didn't highlight the right one. The innermost intercostals. And I didn't add them originally because the innermost and the internals are essentially the same thing. Fibers in the same direction, innervated and supplied by the same nerves and arteries. But there is one important distinction that I want to make today, and that's in understanding how the nerves and arteries and veins travel between the ribs. They will divide the innermost and the internal intercostals, and I'll show you an example of that with the 3D app in a minute. So in keeping up with our habit of naming everything first and then showing you examples, the innervation of our intercostal muscles is by the intercostal nerves. We acknowledge there was a typo in the slide yesterday. They are branches of the anterior rami of the spinal nerves, but we call them the intercostal nerves, and supplied by the intercostal arteries. This is all information that you had yesterday. By now, you know what the intercostals do for breathing. And your textbook has this fantastic mnemonic device to help you remember that the external intercostals lift up the ribs during inhalation. You can sing this to Old MacDonald Had a Farm if you want to. And it's cheesy, but it's memorable. The external intercostals elevate on inhalation. Now I'll show you quickly these nerves and the arteries, and I want to show you the division between the internals and the innermost on the app here real quick. So these are the intercostal muscles. Fibers pointing down and medially, these must be what muscles? Hands in pockets. I think you had it. External, fantastic. External muscles. And like before, we can take a look at the innervation, and let's take a look at the nerve paths. Nothing too surprising. We have the intercostal nerves. You'll notice they're coming off of the, it's hard to see, it's hard to make out, but that's the anterior branch, the anterior ramus, or the anterior rami of the spinal nerves. And they travel along the inferior border of every rib in the costal groove. Remember, we pointed that out specifically yesterday? So we have those nerves. And the arteries, surprisingly enough, look very similar. Arteries look very similar. They probably look very similar because the veins, the arteries, and the nerves for the intercostals all travel together. And I always remember it as a van structure. Just a van. The van structure, they all travel together. Where do they travel is the question. And this is where I want to show you the difference between all the intercostals. So I'm going to get rid of the externals. So I just hid those, cut them away. Now you can see the internal intercostals, 90-degree fibers. I don't see any nerves or arteries yet. If you look way inside, you can see the innermost. Let's get rid of these ones too. There we go. Notice the arteries and the nerves traveling along the borders of each rib between the internals and the innermost. These are the innermost intercostals, and that's why I brought them up today. So that van structure, the nervous supply, the blood supply, travels between those two layers, internals and innermost. Not external and internal, internals and innermost. Maybe that's a question on the final, who knows? If I remember to write it down when I get back, it's more likely to be a question than not. But we'll see. So, as far as intercostals go, that's all we really care about. We want to add to that, those aren't the only muscles on the anterior portion of the thorax, or that stabilize the anterior portion of the vertebral column. There are other muscles that do that, even though they're not really part of the thorax. They are muscles in the abdominal wall that help to stabilize the front portion of the upper body, the front portion of the torso. And we'll see a nice cross-section that shows the layers of skin, the layers of fascia, and how the muscles all overlap and interleave. But I don't want to spend a ton of time talking about all of the muscles. We're going to focus on two in the abdominal series of muscles. And that's because there's two main groupings. There are muscles that wrap around the abdomen, and there is a muscle that attaches vertically, top to bottom, across the abdomen. So we'll take one candidate muscle that wraps around, and our external oblique will be a great example of that. The most superficial layer wrapping around the abdomen. Notice the fibers are not vertical. Oh, I jumped right ahead. Okay. Innervation for the external obliques. Nothing too surprising here. Anterior rami of the thoracic spinal nerves, and that's true. It's not a copy-paste error. And because this muscle originates from, well, ribs 5 to 12, it originates from the lower half of the rib cage. It's in very close proximity to those nerves and arteries. It's supplied by none other than the intercostal arteries. Just like the intercostal muscles are supplied by a similar set of nerves and arteries, so is the external oblique. And I'll show you what that looks like again, but they originate from the ribs, and they have sort of that serrated look if they're well defined, and they insert, really, you can see this big white sheet. It's known as an aponeurosis, and it's specifically for muscles that cover a wide area. It's like a tendon, but it's not a tendon per se. It's a sheet of connective tissue that covers a wide area. So these muscles will insert all the way along this midline and along the, we don't know this yet, but the iliac crest of the pelvis. So this whole white area is the insertion point. Incidentally, that midline all the way up and down is called the linea alba, just the name we give to the midline of the abdomen. I'm starting too high. Midline of the abdomen. So that's the most superficial muscle. The muscle most often associated with abdominals is the rectus abdominis. The rectus abdominis. Rectus, maintaining vertical, maintaining an erect posture. Vertical fibers that run top to bottom, the length of the abdomen, that are separated by some tendinous intersections. These are just bands of fiber that run crossways across the muscle fibers that we think are remnants from development. They don't really serve a purpose necessarily now, but they're remnants of development. So they are there to be seen more easily in some than in others, but they break the contractile fibers across the rectus abdominis and interrupt them as they travel top to bottom. So where do the rectus abdominis fibers travel? All the way from the pubic bone. We talked about the pubic symphysis, allowing a little bit of movement at the pelvis, all the way up to the xiphoid process and some of the cartilages of the ribs. Cartilages of ribs 5 to 7, just along this inner lower X, the meeting point of the rib cage. These ones, also in close proximity to the intercostals, are innervated by, I'm calling them branches of the intercostal nerves. You can just say intercostal nerves, and that's also fine. Technically, they're thoraco-abdominal nerves, but they are branches of the intercostal nerves. You can actually even see them. Humor me for a second. You see the projections down sort of in the middle, the nerves projecting here? Those are the branches that I'm talking about. Same nerves, but just branches or more distal along the nerve. And this is where the uniformity ends. At least in this section, we've talked a lot about posterior rami, anterior rami, intercostal arteries. The arterial supply for the rectus abdominis is different than we've seen before. Something unique, which makes it more memorable. The superior and inferior epigastric arteries supply blood to the rectus abdominis. So let's let's take a look quickly at those muscles. And you probably don't need, let's leave the transverse abdominis, or the external oblique, sorry. Let's just take a look at rectus because we just looked at it. And we'll do it on the left so we have a little bit of space. So there's our transverse ligaments. You can see the entire span of the rectus abdominis. If we take a look at the nerves of the rectus abdominis, projections of the intercostal nerves, no major surprise there. But the arteries are somewhat different. The arteries are somewhat different. So we have superior and inferior epigastric arteries. And this is actually a branch at the top here, is a branch of the internal thoracic artery. But we're sticking with what I have on the slide. You can see where it originates all the way. Well, we won't talk about the proximal arteries too much. That's the superior epigastric artery supplying the top portion of the rectus abdominis. And the inferior epigastric artery coming off of one of the iliac divisions in the pelvis. And we'll get to that detail in future, but you can see there's two separate supplies for the top and bottom of that muscle. And here we see just a nice cross-section to show the layers of those muscles. We're not concerning ourselves with the transverse abdominis and the internal obliques. They're also part of the abdominals that wrap around, although their fibers don't run necessarily in the same plane as the external obliques. We're just not going to add them to our list unless there's any opposition. I can add them if you want. Leave them? Okay. So that's what we want to cover. As far as the thorax goes, the bones of the thorax, the muscles of the thorax, that is our scope thus far. So let's summarize briefly. We've come a long way. There's been a lot of little ingredients mixing together to make this picture. 26 vertebrae, 26 independent vertebrae, or free-moving vertebrae. Sometimes you can consider the fused vertebrae of the sacrum or the coccyx as independent vertebrae as well. If you counted all the individual vertebrae that would have fused, there are 33. But 26 independent vertebrae. And I only make that point about 33 because in the next song that I want to play for you, I refer to 33 vertebrae. So that's why they don't add up. Between all of our vertebrae, we have some measure of cushioning that allows for articulation, small movements, small rotation and flexion. The intervertebral discs allow that. They naturally compress over the course of a day. They expand as you unload them overnight, or with extended leisure periods watching TV. From the vertebral column, we saw the ribs. We identified how the ribs articulate with the vertebral column. We can match the rib number to the vertebra number. We know that some ribs will articulate with 2 vertebrae, and they articulate at the head as well as on the tubercles. Then as we move around and to the front of the thoracic cage, the sternum, the breastbone, the large ishbone in the center connects to the ribs through costal cartilages. And last class we talked about the erector spinae muscles. We were getting into the obliques or the intercostals, but the erector spinae muscles generally are those that keep the spine erect. They run up and down, they run vertically. I like standing from lateral to medial. And they are all innervated by posterior rami of the spinal nerves. Easy peasy. And I won't summarize the few muscles we've talked about today because that's fresh in your mind. There is more information than just this, but that's fresh in your mind. Any questions before we move on? No? Okay. So, let us turn our attention to the upper limb. The upper limb, and that is the upper limb and its connection to the axial skeleton. It is bones of the upper limb, muscles of the upper limb, arterial and nervous supply of the upper limb. Hence why we cover many sections in the book. So, chapter 8, all bones, we'll talk about a couple joints in the upper limb and then get into the muscles, chapter 11, as we move through. Now, the limbs make up the appendicular or appendicular skeleton. Appendages. Appendages to the axial skeleton, the primary vertical axis. And there are many more bones in the appendages than in the axial skeleton. We'll investigate a few key bones of interest and some of their features that are also interesting. And where the axial skeleton, we talked about it having a major role in protecting the viscera, the internal organs, the heart, the digestive system, the lungs, the brain, spinal cord. The appendicular skeleton doesn't protect as much as it allows movement and interaction with the environment. It can also protect. Put your arms up if somebody threw a ball at you, for instance. You can use your appendicular skeleton in a protective mode, but its main function is to interact with the environment. And it is all of the green areas shaded here. The appendages, the limbs, upper limbs, lower limbs, and their points of attachment. So we're going to go through these in detail, but the upper limbs in this section only, before we turn to the lower limbs near the end of the course. Now the upper limbs don't connect in a necessarily simple way to the axial skeleton. Each upper limb connects to the axial skeleton through a pectoral or a shoulder girdle. And a girdle just means encompassing or going around something, surrounding something. Like your belt is a girdle. And the shoulder girdle goes around part of the axial skeleton, part of the thoracic cage. Pectoral girdle is only made of two bones, clavicle and scapula. And those two bones make at least part of a structure that encompasses the thoracic cage. So we've already spent a little bit of time. We've talked about this articulation, the sternoclavicular joint. You've palpated that as you move your shoulder up and down. You can feel the clavicle articulating with the manubrium. And it articulates here at this superior lateral border. And that is the only point of contact. That's the only articulation between the girdle and the axial skeleton. There's no other joint. This is the only part. It's the only part that's holding the girdle on. That's not true. But it's the only joint connecting the axial skeleton and the shoulder girdle. It's kind of impressive. So let's take a look at the clavicle. The collarbone. Clavicle directly means key, because I expect it looks like a key if you hold it up this way. Maybe. Fairly simple bone, sigmoidal or S-shaped. And I'll caution you, I've changed this picture in the slides that are posted on Moodle and here, but your textbook is wrong. Okay, the textbook is wrong. This is the right clavicle, and in the textbook, it shows the anterior surface correctly for the inferior view, but the superior view, it labels the anterior surface as this one, as the topmost surface, and that's wrong. The anterior surface is the surface towards the middle in both cases. So this is correct. The textbook is not right. And that makes sense. You can even just feel the right clavicle. The long, curving 2/3 point out is anterior. And then the short, flatter portion, the lateral 1/3, curves outwards, is concave, more laterally at the acromial process. So just make sure that you understand the arrangement a little bit. We can see the articulation here. The sternal end will articulate with the sternum, specifically the manubrium. And the acromial end, we don't know what that word means yet, but it articulates with the acromion on the scapula. The name makes sense in that regard. Some other features of interest. I think let's only look at the conoid tubercle. There's an obvious protrusion that points down. You can't feel it. It's in the back and underneath. But it's an attachment point for ligaments that try to connect the clavicle to the scapula. And we'll take a look at that on after a couple slides. But let's introduce the scapula first. The scapula, or the shoulder blade. Large flat bone. So probably, what kind of ossification would have made this bone? Large flat bone. Is that an answer? Do you have one? No? What were our two types of ossification? Remember when I introduced the halfway point marks and we had that little talk about maintaining the status quo? Should you keep doing what you've been doing or try to do more? Albeit you wouldn't have had the chance to review ossification between then and now, so I suppose I can forgive you. Intramembranous ossification. Scapula, pretty distinct looking bone, fairly irregular, large and flat, with some key defining surfaces. And I'll point out the first couple here, and then we'll turn to the app quickly. But the acromion, which we just talked about as articulating with the clavicle, very superior, a little wing that comes out over top of the scapula. And also notice the glenoid cavity. That will be of interest in our coming discussion on the shoulder joint itself. That is where the head of the humerus articulates with the shoulder blade. And it's small, right? Notice how small this is. That's not a stable seat for the humerus. Not likely that it will stay there in of its own volition. So let's take a look, and I wonder, can I do this in a way? Let's take a look here. So we're just looking at the joint, and there's some other stuff here. But don't worry about this other stuff for now. We're going to look at that when we get to the shoulder joint itself. Right now, just focus on the clavicle. And the shoulder blade. So the clavicle we are okay with. It's a fairly simple bone, but the shoulder blade is a little bit different. So let's take a look at some of the different parts. So the acromion. This whole surface is the acromion. And the articular portion in front connects to the clavicle. What else defines the scapula? The coracoid process is fairly defining, which translates as a crow's beak, oddly enough. But this projection comes off just superior to the glenoid fossa and is a point of attachment for a number of ligaments that we're going to talk about. And really the rest is the body of the scapula, but there are some important landmarks that we should look at on the body. And the most obvious is the spine, in my opinion. Clearly divides the scapula in two. You can feel the spine of the scapula if you were to try right now. And there's some meaty sections below it and some meaty sections above, and you can trace it all the way over into the front and find your acromion, and then think, okay, if I find my clavicle and then they meet in the middle, that's the acromioclavicular joint. Real world anatomy. The spine of the scapula, nice defining feature. The areas that it separates are important to know as well. And they're long names, but the names make a lot of sense. Supraspinous fossa. Remember, a fossa is a small depression. Supra, above, superior to. Spinous, the spine. Infraspinous fossa on the bottom. And subscapular fossa, below the scapula, on the anterior surface. And I'm bringing these up now because when we get into the section on muscles, there are obvious and important muscles that originate from these positions. So it's important, I think, to talk about them now. And then the glenoid fossa, where our small articulation occurs between the scapula and the humerus. So let's take a look then at the shoulder joint. Briefly. Let's take a look at the shoulder joint. And my interest in the shoulder joint comes from preventing this action. How do you keep the image on the left and avoid the image on the right? Notice the small glenoid fossa, the very small articulation. And as we talk about the joint itself, you'll realize that there's very few structures anchoring the humerus at the scapula. X-rays are one thing, but it's nice to see it in real life too. This is what happens in real life. Doesn't that make you cringe? Ugh, I can't even stand it. I'll flip past. Looks relatively normal, except that you can see the acromion poking out, maybe part of the glenoid fossa, but probably just the acromion. Actually, yeah, that's the acromion, right? Clavicle, acromion, spine along the back. Nice and obvious in this example. So let's talk about the shoulder joint. And what I want to do first is not acknowledge the muscles necessarily, but talk about the more static features that secure the joint. So what we're going to look at are all of the bolded terms. Okay? All of the bolded terms. So first of all, capsule. Fibrous capsule. Synovial joint, fibrous capsule, tries to contain the joint and anchor it within the sheath. It's relatively thin. If I cut it away, see how thin that is? Not a whole lot of stability just from the capsule. Underneath the capsule, 3 different glenohumeral ligaments. Glenohumeral ligaments. Would those maybe connect the glenoid fossa or the glenoid cavity and the humerus? Glenohumeral ligaments? Probably, right? It's in the name. Interesting. These are shown really nicely here as individual ligaments. Superior, middle, and inferior. And you don't have that on the slide. You have one. There are 3 thick sections. And really these are defined nicely in the app, but they are just thickening a thick section of the capsule. They're not very strong in themselves either. So they look like strong, large ligaments here, but they're just thickenings of the fibrous capsule. What is fairly strong is this nice broad ligament on top. The coracohumeral ligament. Might that go from the coracoid process to the humerus? Yeah, it does. Very large, broad, flat, strong ligament that supports it superiorly. You can see the coracoid process here, the connection of that ligament, and it spans all the way across the top of the shoulder joint. Those are really the only fibrous connections of the humerus. The main ones that we're going to look at. A couple other things to note for our discussion later. This transverse ligament isn't part of the shoulder joint itself, but it's clearly obvious here. This anchors the biceps tendon. Keeps your biceps from unraveling or detaching from the head of the humerus, from the shoulder joint. So the biceps tendon goes in, it inserts underneath that ligament and helps to secure it. And then all of these other little pockets or pillows or bulges are all bursae. Remember we talked about what a bursa was? It's like a synovial capsule full of fluid that helps to cushion joints, or the articulation between muscles and joints. This is a good example of that. And you see this one on the sheet that you have in the notes. The subscapular bursa. It's called something longer and different here. But this is a cushion between the shoulder capsule and then a muscle called subscapularis. You don't know what that is yet or what it does, but it prevents those two from rubbing against each other and degrading or wearing them down. What else do we have? You've seen this one as well, which is a pretty nice, obvious place to have a cushion. The subacromial bursa, between the acromion and the shoulder. These don't do anything to secure the shoulder joint. They simply prevent wear and tear. And in fact, the ligaments and the capsule doesn't do a whole lot to secure the shoulder joint. The muscles of the shoulder are largely the main factors in securing the shoulder joint. This is simply a slightly different view. You can see here the addition of some muscles. You can see there's a lot of interleaving and wrapping over and under. Muscles of the rotator cuff, you've probably heard that before. Big impact in securing the shoulder joint. Very important. And we're not going to have a lot of time to discuss it, but I'm just going to show you as a preface for next class. This is the shoulder joint with all the muscles overlaid. So we can see through the deltoid muscle. You can see some of the ligaments that we talked about. And then the rotator cuff, all of these muscles on the posterior portion that connect the humerus to the scapula. And we're going to learn, all of them. It's not that hard, don't worry. What else? And you have this real anatomy slide and a cartoon slide of a cross section through the joint itself. No new information, just a different perspective. Is class done? I didn't get the memo. Yeah, I guess it can be done. Have a wonderful Friday. See you Tuesday morning.